So in this video we're going to talk about nephrotic syndromes and even some specific diseases, but first there are some terms I want you to become familiar with. Remember that greater than 300 milligrams of albumin in the urine per day is abnormal. And so we do have different terms for how severely elevated that is. And so if it's low, say on the range of 30 to 300 milligrams of albuminuria per day, this is called moderately increased albuminuria. In the past, we used to call it microalbuminuria, but we're not going to use that anymore. I think it was actually confusing for some providers who maybe thought microalbumin was like a separate protein, but really what the term meant to say is little bit of albumin. And so likewise, greater than 300 milligrams of albumin in the urine per day is called severely increased albuminuria. It used to be called macroalbuminuria, but to avoid confusion, let's just not use that. I also use this term subnephrotic proteinuria, and this generally describes less than 3 or less than 3.5 grams of protein per day, and it's obviously in relation to nephrotic range proteinuria, which is greater than 3.5 or maybe greater than 3 grams of protein per day. Now it's important to know what defines the nephrotic syndrome. So first you have to have the nephrotic range proteinuria, but you also have these other things. So you have a low serum albumin, you have leg edema or edema somewhere else, and then also hyperlipidemia with possible lipiduria. So next, it's important to know what defines the nephrotic syndrome. So first, there is nephrotic range proteinuria, and so different people define it as either greater than 3 grams of protein per day or greater than 3.5 grams of protein per day. But there's also hypoalbuminemia, so low albumin in the blood. And so most definitions will say it's typically less than 2.5 grams per deciliter. There's also edema, and remember this could be leg edema or even facial edema like periorbital edema. And then there's also hyperlipidemia, so excess lipid in the blood, and or lipiduria, so excess lipid in the urine. So this defines the nephrotic syndrome. So a disease that causes the nephrotic syndrome is a disease that affects podocytes. So somehow the disease is causing podocytes to be dysfunctional and to lose their fine ultrastructural shape. And so here's a healthy podocyte. You can see there's fine foot processes, remember, and there's slit diaphragms in between the foot processes as different podocytes are interlocking with each other, but these have lost that nice structure and they're effaced, and now the glomerulus is leaky. And so remember that on a urinalysis, there's typically no white blood cells, there's heavy proteinuria, typically no red blood cells. Some of the diseases have maybe microscopic hematuria, so I'll put a little asterisk here. Sometimes there's a little bit, but not a lot of hematuria. There's typically no cellular casts, and if there's a lot of lipiduria, so a lot of lipid in the urine, you could see oval fat bodies, which are sort of tubular epithelial cells that have taken up a lot of lipid, and under polarized light in the urine, you would actually see this sort of Maltese cross appearance. The lipid sort of has this appearance under polarized light, and that's one way you can detect this on urinalysis. Also, there's some other medical complications of nephrotic syndrome. For one, there's lipid abnormalities like hypercholesterolemia and hypertriglyceridemia. It's thought that the low oncotic pressure from the hypoalbuminemia leads to enhanced hepatic synthesis of lipoproteins, and that leads to the hypercholesterolemia. The hypertriglyceridemia, still not sure why that happens. And then also there's a hypercoagulable effect that comes with severe nephrotic syndrome. So patients can be prone to venous thrombosis like DVT, PE, and also something that is kind of unique to patients with nephrotic syndrome is the occurrence of renal vein thrombosis. Okay, now let's spend some time talking about diseases that can cause the nephrotic syndrome. So first is this disease called minimal change disease, and so this is isolated dysfunction of the podocytes. And so a patient with abrupt onset of nephrotic syndrome would likely get a kidney biopsy, and this is kind of what the glomerulus would look like on kidney biopsy. There's no scarring or sclerosis, and actually it looks histologically pretty normal. But then what we would do is send it for electron microscopy, and on the EM you would actually see foot process effacement. So this is that glomerular basement membrane right here, and this is the filtration barrier, but instead of seeing this nice filtration slits and nice foot processes, the podocytes are spread out thin, and they're not forming those nice filtration slits. And so we see diffuse foot process effacement, and that's what is essentially responsible for the massive proteinuria and the nephrotic syndrome. And so this is the most common cause of nephrotic syndrome in children, and it's quite responsive to steroids. So corticosteroids typically treats this. So next is this disease called FSGS, or focal segmental glomerulosclerosis. And so the term is, we're really talking about the histology here. So focal means some of the glomeruli are affected. So if you're looking at all the glomeruli in the sample from a kidney biopsy, some were normal, but some are affected. And then of the ones that are affected, a segment, only part of the glomerulus is affected. So how is it affected? By scarring or sclerosis. And so this picture here is trying to represent what you would be seeing. So as you can see, this part of the glomerulus is healthy and this part has sclerosis. And so focal segmental glomerulosclerosis. And then we would process it under electron microscopy, and what would we see? We would see the foot process effacement and podocyte dysfunction, just like we saw in minimal change disease. The only difference is that now we're finally seeing sclerosis. And some people think that minimal change disease and some forms of FSGS are kind of on a spectrum, and we're catching them at different times. Likewise, if caught early enough, the lesions start in segments, but can eventually result in global sclerosis. So global would mean the entire glomerulus is now scarred down, and this entire thing would just look like a big pink blob. Okay. Also, there's typically absence of immune deposits. So as far as we know, this is not mediated by immune complex deposition, for instance. One thing that's confusing about FSGS is that we use that term to describe the histology, but it's also the term we use to define the disease. And I think, frankly, it's a disease maybe we don't know enough about yet to give it a different name. So we use the histological term to name the disease, and that can be confusing for some learners. One thing that's important to know is that what leads us to a kidney biopsy is proteinuria, nephrotic syndrome, with or without abnormal kidney function. And so imagine that we did a kidney biopsy on a patient, we saw FSGS. Now we have to go back to the drawing board and run the differential for what are all the things that could lead to that. And so one thing is just what we call primary or idiopathic FSGS. And so this is a patient who typically presents with sudden onset nephrotic syndrome. On the electron microscopy, there's extensive foot process effacement of nearly all the podocytes. And so it's some process that's occurring that is causing glomerular permeability and podocyte injury and leading to that loss of structure. And so we're not entirely sure what's causing this. Some people think there's some circulating factor that's causing podocyte injury. But basically, we screen them for any other risk factors associated with maybe a secondary FSGS, and we come up short. So it just seems like this patient out of nowhere is being affected by podocyte injury leading to nephrotic syndrome, and we call that primary or idiopathic FSGS. So some patients with primary FSGS actually respond to immunosuppressive therapy, specifically glucocorticoids, and sometimes we use things like calcineurin inhibitors. Typically the patients who get treated are only the ones who have full-blown nephrotic syndrome and perhaps also kidney worth saving. That is, not a lot of global sclerosis and not a lot of interstitial fibrosis and tubular atrophy. Next, there is this entity called secondary FSGS. So this is basically podocyte injury due to adaptive glomerular hyperfiltration due to some other cause. And so what are the different things that can lead to glomerular hyperfiltration? Well, one, reduced renal mass due to maybe congenital solitary kidney. Maybe at a young age someone had to have a nephrectomy. So over time that leads to adaptive hyperfiltration of the remaining functioning kidney. Also, obesity can cause an obesity-related FSGS that's secondary in nature, sickle cell disease, and then eventually diabetic nephropathy results in a secondary form of FSGS. And so in this case, on the biopsy, there's only focal foot process effacement. It's not diffuse. Maybe less than 50% of all the foot processes that are visualized show that foot process effacement. So when there's FSGS with scattered foot process effacement that's not diffuse. And there's some other cause for adaptive hyperfiltration identified on the history. We call that secondary FSGS. And there are some other rare causes like heroin injection. Some drugs like interferon, pamidronate, and anabolic steroids have been associated with this. And there is an infection associated form of FSGS, and this is also called HIVAN, H-I-V-A-N. And this has been described in patients who have very high viral loads of HIV, and then it causes a collapsing variant of FSGS, and it actually affects the entire glomerulus, and it sort of looks like it's collapsing down on itself, and like it had the air sucked out of it. And so this is rare nowadays, but it still may show up from time to time. So finally, there are hereditary forms of FSGS that we would call familial FSGS. And so, as expected, these diseases involve mutations that affect proteins found in the podocyte, like nephrin, podosin, and TRPC6. And so, when dysfunctional, these proteins somehow affect podocyte function, which leads to podocyte dysfunction and eventual injury, and then FSGS. And so this is why in all of our patients who have FSGS, we try and take a good family history to determine if this is present or not.